We're joined on the line by Dr. Amish Adalja. He's a senior scholar at Johns Hopkins University Center for Health Security. His work is focused on emerging infectious diseases, pandemics preparedness, and biosecurity. He is an external advisor to the New York City Health and Hospital Emergency Management Highly Infectious Disease Training Program, as well as the FEMA Working Group on Nuclear Disaster Recovery. Dr. Adalja, thanks so much for joining the Ben Shapiro Show. Really appreciate it.
Thanks for having me.
So why don't we begin with what Americans can expect over the coming months, over the next year? I've been wondering what exactly people are expecting to change in any dramatic fashion such that we will be able to go back to work. So I want to start from the angle of a vaccine. People keep sort of suggesting that things won't go back to normal until there is a vaccine. What are the actual chances that we are able to develop a vaccine at all for something like this? We don't have great history of developing vaccines for coronaviruses in general. And when it comes to this coronavirus, we actually don't know that much about it and how fast it is mutating. What do you think are the possibilities we actually are able to develop a vaccine that's particularly successful?
I'm fairly optimistic that we will be able to develop a vaccine. While it's true we don't have any human coronavirus vaccines, there are highly successful veterinary vaccines against coronaviruses. And you have to remember that people really only started thinking about coronaviruses as a threat in 2003 after SARS. And that virus basically disappeared and vaccine development stalled. So it's not that we haven't that we've had difficulties making coronavirus, it's that people haven't really tried. And now there are many candidates that are out there right now. One already is in phase 2 clinical trials. So I'm pretty confident. And this isn't a virus that mutates the way that flu does and mutates away from vaccines. So I'm hopeful that a vaccine for this will be more like a measles type of vaccine, but it's still 12 to 18 months away before we have enough vaccine to vaccinate the world.
So in the meantime, obviously, there's a lot of talk about some of the mitigation treatments that may be made available. There's one from Gilead Sciences. There have been some studies of hydroxychloroquine which suggest that it's actually counterproductive, that it's not particularly helpful. So what are the drug options that are on the table for mitigation in the near term? Because we're obviously not going to lock down for the next 12 to 18 months.
So in the near term, remdesivir, which is a Gilead product, is looking promising. We have some data that's coming out. It's not from randomized controlled trials yet, but there are randomized controlled trials going on. So people are very hopeful about that drug, especially in hospitalized patients, to decrease the mortality, decrease the need for a mechanical ventilator. Hydroxychloroquine has been something that people had a lot of buzz about and a lot of hope for, but most of the studies are showing that this likely has a very marginal, if any, or maybe even a negative benefit in people. We still don't have randomized controlled trial data, and it really shouldn't be something that we're using at this point outside of randomized controlled trials because of the emerging data on it. We are also trying to give convalescent plasma, the blood of recovered individuals, to patients, and that may be also something promising in the near term as well. So there are some things that will help us to decrease the mortality, but we don't have an oral pill that you're giving people to cure them of this disease or anything like that. So we are still going to have to do some amount of social distancing and just being much more smarter about how we face this virus in the future, because the real fear is that as we start to ease lockdowns, that we end up getting a flare that puts hospitals into crisis. And that really has to be the markers. Can we keep the rate of cases low enough that we don't inundate hospitals?
And Dr. Amish Adalja, senior scholar at Johns Hopkins University Center for Health Security. So let's talk about exactly the measures that have been taken so far. Obviously, we've locked down. It seems like there's been widespread misinformation or at least misunderstanding of what exactly flattening the curve was designed to do. From what I read and what I've studied and talking with people like you, what I've been told is flattening the curve was designed to prevent us from exceeding the capacity of our healthcare system. It's not designed to prevent the general level of infection in society, because it won't. I mean, the fact is that as long as this exists out there, as long as there's human contact, it will be out there, that the area under the curve will be the same. It'll just be a lower curve. It may take longer for more people to be infected, and hopefully that buys us time for new drug treatments to be available and to not overwhelm our healthcare system. Same sort of thing with testing. Testing is not designed to stop the disease from spreading entirely. It can't do that. Testing is basically, and contact tracing, those are designed to prevent epidemic flare-ups that would exceed the capacity of our healthcare system. Is that accurate?
Exactly. That's exactly correct. Flattening the curve is really about just decreasing the rate of increase of these cases so that we don't get our hospitals into crisis. We don't have what happens in New York, that happened in New York City, happening to other parts of the country. We still may end up getting the same number of cases, the same number of deaths over time. Like you said, the area under the curve may be identical. It's just that the rate of the cases is going to be at a low enough clip that hospitals don't go into crisis, don't have to change their operations, don't have to worry about excess deaths from other causes because of hospitals being so crowded with COVID patients. So yes, that's really what this whole thing has been about, and that's sometimes not disseminated very well to the general public. But this is what it's about.
So, are you hopeful that by September there are going to be any real changes in the status quo? And the reason I ask is, my kids are going to end up going back to school in September. Right now, my parents are over at our house a lot. My parents are in their mid-60s. They're both in good health. My dad is on some medication for high blood pressure, although it's fairly mild. But my feeling is that, I won't send my kids to school so long as my parents are over here. They're not going to summer camp so long as my parents are over here. And if they do end up going back to school, if nothing changes in this status quo, I'm basically going to have to tell them that they need to go home. We've been able to lock down with my parents, but when that lockdown ends for me and my children, obviously the risk factors change for my parents. Do you see any changes? I think a lot of people are in the same situation. Do you see any changes happening by September that justify enthusiasm about the ability of families to hang out together, or social distancing to come to some sort of end, by that period?
I do think that even in September, there are going to be high-risk individuals, those that are elderly, those that have medical conditions, that are still going to have to be very wary about their social contacts because they could still be infected. It may be that we will be in a better place when it comes to diagnostic testing, health department capacity to do contact tracing, and hospital capacity planning, meaning that they have personal protective equipment, they have access to ventilators. All of that's going to be better, but there are still going to be people that are at high risk for getting infected, and people are going to have to still take some precautions. There may be some antivirals that will make the case fatality rate or ratio go down, but it is still something that we're likely to recommend that those at high risk continue to try and observe as much social distancing as they can tolerate.
So speaking of the case fatality risk, what do you think the actual case fatality rate is? So obviously we've now seen antibody studies from a variety of sources. We saw one in Santa Clara. It's controversial. We saw one from Denmark. We've seen one from Iceland. We've seen various antibody studies, and all of them suggest that the number of infections is really, really a lot higher than the number of actual identified cases, simply because so many of these cases are asymptomatic. That does mean that this thing is not only far more widely spread, it also means it's very hard to tamp down, because if you're transmitting asymptomatically, we're not going to get to the point where we have 20 million tests a day in the United States, as was suggested by this Harvard study. That's just not a thing that's going to happen. So what do you think the actual case fatality rate is? And is it anywhere near what the WHO originally said, which is 3.5% to 4%?
No, I don't believe it's anywhere near the 3 to 4% estimates that we were getting from China based on what was a sample that had a severity bias in it because of who was getting tested. This is likely below 1% and maybe 0.5% or lower. And it really has to do with understanding what the denominator is, and we don't know what the denominator is. But that shouldn't make people breathe a sigh of relief, because the fact is there's no population immunity. So a small percentage of a big number that are going to get infected is still a big number, and that's what we're still worried about. So there's, I think, less emphasis on the case fatality ratio, more emphasis on what the hospitalization ratio is, because that's what we're really worried about. Again, going back to what flattening the curve is about, is preserving hospital capacity. So if a large number of individuals need to be hospitalized, that's what we're concerned the most about, and trying to understand what that is. And it looks like the hospitalization rate was overestimated in some of the models, but it's still enough that it could put hospitals into crisis in certain places where there's high population density and where hospitals are already stressed, like what we saw in New York City.
So, Mr. Being Dr. Amish Adalja, you've been watching as some states have been talking about reopening. Obviously, the reopening of the country is going to have to be done differently in different areas. New York is a real outlier when it comes to population density. Georgia does not look like New York. There may be some areas of Atlanta that are riskier than other areas of Georgia. But overall, there are states that are just much more spread out. Los Angeles, where I live, most people live in the suburbs. The public transportation system is not particularly well used. We haven't seen a massive outbreak in Los Angeles or anything even approaching what has happened in New York. With that said, how fast do you think we can move back toward businesses reopening? And should we really be focused on businesses and how businesses operate, or should we be focused on which populations actually should be allowed to go back to work? So one of the things I've been focused on in discussing COVID is the fact that it has a very different effect on very different populations. If you're under the age of 40, the chances that you're dying from COVID-19, if you're healthy and don't have a serious pre-existing condition, are almost zero. I mean, they're extremely, extremely low. If you're under the age of 20, they basically are zero. If you are between 40 and 60, then they are higher than the flu by a fairly significant margin. And if you are 60 and above, then they really start to grow dramatically. So instead of focusing on what kind of stores people can and cannot be going to, shouldn't we really be focused on which kinds of people are least susceptible to the disease and telling those people that if they can, they should go back to work?
I think it has to be both. We are definitely going to have specialized messaging for those that are at high risk, and they're going to try and encourage employers that employ individuals that are high risk to allow them to telecommute more and to really be more flexible because they are at a definite risk of hospitalization and death at a higher rate than people in the younger groups. But I do think that what we're going to see is certain businesses start to open, ones that are able to do some amount of social distancing, because there is still the concern of you transmitting it to somebody that's at high risk. And I think that's still motivating a lot of policymakers here. And it is definitely true that not every state, not even every county in a state is the same. And you are going to see kind of heterogeneous types of plans being made in one part of the country or one part of a state versus another based on hospital capacity, diagnostic capacity, health department capacity, and where they are in their epidemic, meaning have they had a lot of cases already? Are their hospitals already stressed with this or not at all? And I think that that's what you're going to see, kind of a rolling reawakening. Certain things are still going to be very difficult to have, such as mass gatherings, which will be something that most cities will not be able to handle if there were transmission in high levels at a mass gathering. But I do think you're going to see schools, businesses starting to open, maybe with some modifications. And I think as we get further along, the risk perception is going to change somewhat as well. And people are going to become more comfortable with living with this because they're going to realize that this didn't magically disappear. And this is going to be with us until we have a vaccine. And we've got to find a way that we can live with this and go about our lives, as well as not allow the virus to be as disruptive as it has been, by ensuring our hospitals are prepared to take care of the cases that we do get.
So, Dr. Adalja, one of the controversial areas has been strategies taken by different countries. The obvious kind of candidate for controversy is Sweden here. I've said for a long time that you're not going to be able to gauge whether Sweden made the right decision or not until the vaccine is developed, and you look back over that period of time and see whether Sweden experienced a higher death toll per capita than countries that surrounded it. It's very easy to point to Sweden and the fact that they have more deaths and more cases and say, well, you know, if you look next door at the Netherlands, they don't have as many deaths and they don't have as many cases on a per capita basis. But that is because Sweden has behaved differently. I mean, if we were not in lockdown right now, presumably there would be more deaths and more cases. The top epidemiologist over there is now saying that Sweden is approaching 20% infection rate, and which means that over the past couple of months, they're quickly approaching herd immunity if they continue to keep up those sorts of infection rates. If you assume herd immunity is 60%, is Sweden wrong to do what it's doing? And could that model be applied in the United States, or is the risk so large because of our huge urban areas that we simply can't do something like that? It's basically batten down the hatches, stop and start, and socially distance until we have a vaccine.
What Sweden is attempting is something that's very daunting, and we don't know how successful it is. And many people in my field think it was the wrong decision. It's something that's really hard to weigh because the premise of herd immunity makes sense. However, it's very hard to keep those high-risk individuals from getting infected. And we know in Sweden that they've had a lot of problems in nursing homes, for example, getting infected, as we have here as well. And that's going to be a trade-off that they're going to have to try and reckon with. And I think it's really hard, and we won't only know really at the end whether or not they're successful. But there have been a lot of criticisms of Sweden based on this. But I do think that the facts will actually bear out whether or not this was an effective strategy or not. And it would be very difficult to do something like that in the United States because of the population size, the highly dense cities that we have in certain areas, and we would likely see hospitals go into crisis because they almost went into crisis in New York City without doing that type of a policy. So I think that would have probably pushed certain cities into a place where they were thinking about rationing ventilators or really having to turn people away. And just because New York got close to that or close-ish to that with us doing social distancing. So I really wonder what would have happened with that. So it may not have been something that you could do in a country like the United States, especially in cities like New York.
And Dr. Amish Adalja, senior scholar at the Johns Hopkins University Center for Health Security. Really appreciate your time and your insights, sir. And thanks so much for all the work you're doing.
Thanks for having me.